Mama, I got bad news, bad news. I've been rolling with some bad dudes, bad dudes. I've been trying to get a bag.
Hello, listeners. Welcome to the Ashes to Awesome podcast, Rising in Recovery. Our podcast provides light, hope, and understanding about addictions and mental health to people living within that life and the people who love them. Today's episode is brought to you by Yacha Treatment Centers in Phuket, Thailand. They are a clinic run by clinicians, not a business run by businessmen. And they know that where addiction is the smoke, trauma is the fire. Learn more at yachacenters.com. That's YATRACENTRE.com. Hello, listeners. Welcome to the Ashes to Awesome podcast and another episode of the Weekend Ramble. I'm your host, Chuck LaFlange, and of course, I have my lovely co-hosts with me today, Dr. Lisa. How are you doing today?
I'm very good, Chuck. How are you?
I'm fantastic. And Attica J is back for her first, I guess it's your first episode as a co-host, what I call a probationary co-host when I was talking to you the other day. How you doing today, Attica?
Good. I'm honored. And how are you doing, Chuck?
I'm excellent. And of course, we have a guest with us today, and I wrote a big, long introduction for her. There we go. Okay. He's a trailblazer in internal and addiction medicine from Alberta. He stands out for his unwavering advocacy for vulnerable groups, including the Indigenous, LGBTQ, refugees, and those confronting addiction and homelessness. He's a respected academic at the University of Alberta. He has pioneered vital health initiatives from virtual interventions to detox programs. He's celebrated for his published work as the president-elect of the Alberta Medical Association Addiction Section. Our guest has been instrumental in transforming healthcare perceptives and policies. Welcome to the show, Dr. Monty Ghosh. How are you doing today?
Doing well, thanks. Thanks for having me here.
Hey, thank you. That was a long intro. I guess I should have practiced it a couple times there, but it speaks to the caliber of guest, I guess. Eh? So you are. Well, I mean, you're a medical doctor. You specialize in addictions, correct? Right?
Correct. Yeah.
Yeah. Okay. Why don't you just kind of give us how do you get here? Why is it that you ended up in addictions and became a doctor in the first place? If you want to kind of give us a short rundown of that.
Yeah, totally. I mean, it's very much a journey, and it took lots of twists and turns, if you may. But I started off wanting to do global health. So that was my big focus, was to be overseas, working in communities that are underserved and underprivileged. And so that was the big goal of getting into medicine. And people who know me know I love to travel. That's like one of my big things. And so that was part of the impetus as well, to do global health. Okay. And then I got into medicine. And then I went down the rat race of medicine, which, I mean, I think Lisa could probably talk about as well. And you get into this sort of rabbit hole of trying to get into the best specialty you can and whatnot. So I actually got into ENT when I matched at the U of A. So ENT is ear, nose, throat surgery.
Okay.
So I did 3 years of that. And then I remember in my third year of ENT, I was like, okay, this is not me. This is not what I was, meant to do. And this is not part of my journey. And there's different factors for that. I think, like these patients were very different than what I was used to. A lot of them, were doing rhinoplasty, so nose jobs, things like that. And people were never satisfied fully with what they got. Yeah. And my heart was somewhere else. And so I switched specialties. I was trying to get into family medicine, and I couldn't get into family medicine. So I went to internal.
Okay.
And it worked well. I think I started doing internal medicine, started going down that journey, really enjoyed it. And then I decided towards the end of my internal medicine journey that I wanted to move back to Calgary.
Are you from Calgary then? Yeah.
Born and raised in
Calgary. Yeah. Okay.
And my family's still here in Calgary, and my father was going through chemo at the time. And so I'm like, okay, you know what? I need to move back. And I came back to Calgary, and I couldn't find a job. And so it's easier, I think, for family medicine to find jobs. Like you can just kind of set up shop, but for internal medicine, it's mostly hospital based.
Yep.
And in Canada, that is. And so it was, I couldn't get a job. And so the only place that could hire me was like the Alex and the drop-in center. And so I which is our shelter, and so yeah, I started off over there as an
Wow.
internist, and probably the best thing that ever happened, to be honest, in my mind.
No kidding, eh? No kidding.
Yeah, so yeah, it was there, and then I met lots of mentors from that avenue.
Okay.
And I remember I decided a master's in disaster medicine. I was planning to go back overseas and work with Doctors Without Borders, but then with my father being sick, I decided to stick around a bit longer. And one of my mentors, Martin Labrie, was like, why do you want to go overseas to do global health when if you look around, there's just so much need here, right?
Right.
And
Right.
Martin's been amazing because Martin like lived through so he was like one of the original doctors in the early 70s before we had our not-for-profits in Calgary that like our not-for-profit health center. So he was walking the streets of downtown Calgary taking care of patients. He was part of the HIV epidemic, like so he was a palliative care doctor and he would take care of HIV individuals. And
Okay.
back then you
Okay.
had no treatment. All they
Yeah.
would do is pass away. And then they
Yeah.
started getting treatment, and Martin started prescribing it. So like Martin's a huge inspiration to me, to be honest with you. And and
No
uh,
kidding.
and so you can just Google him and find out a lot about him. But yeah, so he's kind of an inspiration to me, kind of pushed me in this direction, and
Yeah.
it's been like that ever since. I've been kind of working in this sort of area intersection between internal medicine, vulnerable populations work, substance use concerns, harm reduction. It's been kind of this sort of area, this triangle that I've worked in, and it's gotten bigger and bigger and busier and busier.
Yeah. No
Uh,
kidding, eh? No
but it
kidding.
all started off with just working in a shelter and working with underprivileged individuals and like I don't know, Lisa, I don't know what your thoughts are on this, but I remember thinking that it was like not a glamorous job. People when they finish internal medicine usually like, oh, I get a big hospital job, and I'm in the thick of it, and you're in an academic position, but none of those opportunities were available to me at the time. It was just you work your shelter job and no academic
Yeah.
appointments. You can't get grants, you can't get projects off the ground. You just do your thing.
So
Uh,
and I think it's interesting because one of the things, and for me, right, I had a career pre-medicine, right? Like I worked in industry as an engineer for 6 years before I went to med school. And I think that in general, people have this perception that being a doctor is just a glorious job and that it's, um, you can have whatever job you want and you make all kinds of money and that everything is really easy. And for me going through it, especially being older and having, I think, a different lens looking at medical school and what it takes to become a doctor, like that changed a lot. Like it's a slog. Like it is not easy. And like my background's engineering, that wasn't easy either. I can tell you medicine is not easy. And it's not just the content of the knowledge you need to learn, but it's the training that they put you through, the forcing you to be awake for 36 hours, the like yeah,
No kidding, eh?
constantly, being under a spotlight, be having, you haven't slept in 24 hours and you got preceptors who are coming at you with questions and you're like, I can't even remember my name right now. So it's not an easy job. And then what made me think of all this is just like Monty talking about here we have this trained internist and he can't find a job. Like people don't realize that it happens a lot in medicine. I think a
No
lot,
kidding.
especially in like surgical programs, because if there's no OR, then even if you have patients lined up, for blocks, it's like there's nowhere to operate on them. And so you can be this incredibly trained, specialized surgeon and you can't find a job.
Kidding.
But it's still crazy, right? That you've got someone like Monty who's a trained physician and he's like, walking down the street, knocking on shelter doors, looking if somebody will give him a job because he can't find work.
That's
Like, that's
crazy.
kind of
That's
crazy.
it really
Like,
is.
It
It really
is.
sad,
is, right? Yeah. Yeah.
But I have a question. So I didn't know you had done ENT. I feel like that's the first time I've heard that. So you did 3 years of ENT, and then when you switched to internal med, did you get any credit or did you need to start over from year one again?
that's sort of from year one again, almost all. I think
Oh,
I got
Oh
like a
my
few months of credit.
God.
Yeah, like a couple
that's
months, I think, and that was about it.
okay.
But I really love internal medicine, and I
Mm-hmm.
think everything happens for a reason. Like you don't know it at the time.
Mm-hmm. That's true.
And so internal medicine was the right path for me. I do internal medicine at the U of A now at the University of Alberta Hospital, which
Okay.
is one of our academic hospitals in Edmonton. So I do weeks of internal medicine up there, and then on the weeks that I'm not doing internal medicine, I'm in Calgary, working at a few clinics, and so at the Calgary Drop-In Center, but at other programs as well. And yeah.
And Monty, where did the interest in addiction come into this? Because it's like you talked about sort of that interest in global health and traveling and marginalized populations and underserved folks, but then you ended up at the shelters in Calgary. Is that when like the sort of specific addiction interest evolved or?
100%. I mean, most of the cases that we're dealing with were substance use related,
Yeah.
and it was something that we never got trained or taught in undergrad or residency.
Yeah.
It's better now, but because now there's so many of us who sort of teach residents about substance use concerns, but back then there was nothing, and that's just like, I mean, I just graduated from residency in 2016, so it wasn't that long ago, like it's and so yeah, it was there that I kind of got interested in addiction medicine. It was there that I started meeting connections and making connections with people like Rob Tanguay and Dr. Lim and others, and so started shadowing and doing sort of informal fellowships and training with them for almost over a year-long time period, and
Li-
and then kind
Lisa,
of
you had
ventured
said
out
there
on
is
my
no
own.
separate fellowship for addiction, right?
No, there is now.
Oh, there is now. Okay,
So
okay.
there's, yeah,
Yeah.
there's a
Yeah.
1 year program that you can do. And then I think right now in Calgary, at least, and correct me, Monty, if I'm wrong, but I think it's actually more through family medicine, isn't it?
Correct,
Or
yeah.
there's more
Hmm.
family med residents who go into it for whatever reason.
Hmm.
Um,
Okay.
yeah,
Okay.
yeah,
Yeah.
What
yeah.
do
And
you
there's a
like the
psychiatry
most
one too.
about
Oh,
what do you like the most about addiction medicine in terms of like the patient? Because I like sometimes I feel like it's, correct me if I'm wrong, but you choose a specialty because the base of the science of it or the patient population that you get to deal with. So I'm curious about your thought process when you're choosing addiction medicine.
Yeah, I mean, I love the breadth of patients, to be honest with you. You see everything from high socioeconomic status individuals to people who are highly, highly vulnerable living off the streets. So it's totally variable, different needs. It's very complex. And I think the most interesting part of addiction medicine is that it's this weird confluence or intersection between different sectors that don't usually intersect. So you have the health sector, which is part of medicine. You've also got the social services side of things. You've also got justice often that often intersects with this too. And then you've got government policy.
Hmm.
And so it's a very complex sort of intersection between all of these areas, and it's very sort of difficult to navigate, if you may. Like policy affects the system, which affects the patient care. It's all intertwined, and that's why I really love this. It's just very you have to kind of navigate through all of these systems. Like I have to navigate through the social services sector and system all the time with not only my patients, but as an advocate, as a researcher. I have to go through the government officials all the time and understand public policy, and why certain pieces of policy are made the way they are, and is it evidence based, and is it based off of research? It's so important to do that as well. And
Or
then
stigma.
our stigma,
Yeah.
yeah,
It's
Stigma,
a
it's a big
moral
thing.
beliefs,
model, right? Yeah. Yeah.
theology.
Yeah. Yeah.
And then there's also, I mean, I also find the justice system is very much intertwined here. And so, like, I
Hmm.
have to constantly, like, I had meetings with the RCMP yesterday. A week prior to that was at the CPS group or the Calgary Police Department.
So speaking to that specifically, the Monty, I'm sorry to interrupt you.
Mhm.
Um, have you seen, and because I feel like you started about the right time to see kind of an evolution in the drug economy or drug world, or not evolution, but a migration maybe to a different kind of thing. Have you seen police specifically? Have you seen their attitudes change across that time as well? Have you, for the better, for the worse, for right?
Yeah, you know what? I don't know if I've seen a change per se, but I've seen like them really like I've always felt that they were very open. They understood that addiction wasn't a moral failing or a justice issue. They all like they most of them feel it really is a mental health concern. It's
Yeah.
a medical condition.
Okay.
And
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 I suppose
so
they're
I've never
stereotyped like
felt that
anybody
way.
else's, right? But
Yeah.
yeah, yeah. Okay.
And now I know there's people out there who do feel that way for
Yeah,
sure. Like
strongly. Yeah,
strongly,
yeah, right.
exactly. And
Yeah,
then you hear stories, you see comments being left on internet threads and stuff like that. But for the
yeah, of
most part, the
course.
people that I work with, they're very caring, compassionate people.
Okay,
Um,
okay.
And I think too, like, I don't know what your thoughts are on this, Monty, but like the police officers that would be engaging with you, the police officers that will be having conversations with you, they're a subset. And I think, I think like in
Yes.
in any realm of life, right? Like whether we're talking about lay people, police officers, physicians, clerks at a grocery store, you're going to have a gamut, like you're going to have a range of people, because I feel like that as well. Like I have had really great experiences with Calgary police. I have a patient right now in the hospital who's connected to PACT because he's got a forensic history, he's got a mental health history, and there's a police officer who comes in, and like this guy's not able at this time to go off unit alone. He comes in every single week. He takes this guy for burgers. They go outside the hospital and play basketball. He's working with our social worker to try and find this guy housing because he's like, we cannot send this guy back to shelters in the streets. Like he's vulnerable. This is not okay. And so, like he's incredible. But again, he chooses to work in a branch of the Calgary Police Service where I think people passionate about this would spend their time, right? So,
I've never
Yeah.
seen a police like that.
oh, it's
Not in
amazing.
Vancouver. Yeah.
Yeah.
But you
Yeah.
guys have a special situation out in Vancouver, though, right? Like
I,
things are
it's
crazy
a
out
bit
there. I mean,
different.
yeah,
Our police
yeah,
is a little
yeah,
bit different.
yeah. Well, yeah, your
I'm
mayor
actually
trying to
quite
defund them for
surprised
a
that
while there, right?
yeah, I'm actually quite surprised that the police would, have like an open, friendly meeting with you, Monty, because I don't know if they're gonna have a friendly meeting with healthcare professionals over here.
Really?
But
that's
mind you,
okay.
the
And I
dynamic in
do.
Vancouver is individual to Vancouver, though, right? Like the mayor,
Yeah, maybe.
like tried to defund them, like by $6 million a couple of years ago, right? Like he was actively a part of this whole defund the police campaign, right? The mayor of
Oh,
Vancouver was, yeah, right. So they've got like
Well,
a
because
really things
they
are
try
messed up out
to
there, right? It's like,
well,
yeah,
because they
yeah,
try to do the street sweeps, and
yeah, yeah,
basically they
yeah.
used to do it once every day, and now they do it like 3 times a day, and just
Yeah.
like
and what
you
does that
know
entail? Like, what's a street sweep look like? What do they
it's
do?
when you take away the camps and stuff. So you take away the
Oh,
yeah, so I've heard people saying like, okay, well, but they have shelters to go, and I'm like, well, shelters aren't always the same. Like some shelters are good. Usually women's shelters are very good. I've been to the women's shelters, and I would be like, you know what? This is really nice, but most of the men, like especially older men who are more vulnerable, they don't have that choice. And usually the shelters that are mixed, and those are shelters like lots of bed bugs, and
mhm.
shared bathrooms. And you know what, like if someone tell me like, oh well, but they have shelters to go, I'll be like, why don't you go into that shelter and like actually spend a night? Well, how
Mhm.
about that? Because like I've seen those shelters, and I personally cannot handle it. Like I would do my business outside, you know, because it's pretty
I agree.
gross.
I've had that exact conversation with people who are sort of
Yeah,
dismissive, and they're like, "Oh, well, they can
yeah,
they can just
they
Oh
hit
can
yeah,
that thing,
yeah,
right?"
just yeah.
And it's like, yeah, if you've gone, like I went to Alpha House one time, I've been to the drop-in center, and it's like, if that was the only option available to me, like, yeah, I wouldn't be super excited about it. And the other
Mhm,
thing with shelters for some patients is people have PTSD, they've got trauma. And for some people, shelters are terrifying, you know?
mhm.
The other thing I've had clients tell me or patients tell me is that, like, particularly folks who are trying to abstain from substance use, they're like, it's the worst place for me to go. Like everyone there, there's so many people using around there. I've had patients tell me that like if they're not using, people will come up and like offer to share with them or to use with them. And so people are like, if I'm trying to stay off drugs, like it's not a good place for me to be. And so they'll try to avoid it, which is super sad.
story.
Yeah.
No, indeed, and you have to be very, very like cautious about that stuff. And it's. But I mean, going back to the whole stigma and police, I also feel that maybe it's because of my privilege as a physician,
Yeah,
and
yeah,
that they often are probably treating me with a bit more respect than my colleagues.
yeah, yeah,
Um, so I mean that could
Yeah.
factor in as well.
yeah,
Yeah.
yeah. I don't hold any of those negative feelings towards the police, but well, our my first co-host here with the show, Carl, we know he sure does.
Yeah.
Right? But yeah. So I mean, he's an Indigenous guy too, so there's that dynamic in there
Yeah,
as
I
well,
think
right?
I
So
think there's that because
yeah,
I do deal with a lot of
yeah,
indigenous and native patient population, and I do see
yeah,
where their trauma came from, especially after they went to the jail, and it's
yeah,
like it's so traumatizing, and everyone who wears you know um uniform, even if you're a healthcare professional, it's like, what are you gonna do with me? It's
yeah,
like, are you an enemy? Like, what are you gonna do? Are you going to torture me? So it's like,
yeah, yeah.
yeah, I've seen quite a bit of that, and yeah, I mean, anecdotally though, from my experience, like, I I haven't seen a case where like the police actually protecting, but I don't know. So. I don't know.
Yeah.
So we talked before the show, Monty, about your innovation in equity. Why don't you tell us about that? I thought that was a really great read. What I was reading there, if you could.
Yeah, I mean, I think one of the things I sort of really strongly believe in is this whole idea and concept of innovation for equity. And I think we don't innovate often for the purposes of equity, and that most innovation comes out of necessity sometimes, often. That I mean, that's the number one reason, but also because of
Yeah,
profits,
of
other
course.
motivations, not really equity, right? Equity is not really
Hmm.
that sexy, and so I think that's what we really need to focus on as a society is making sure that's more equitable. And there's ways to innovate around that. Like it doesn't need to be, we you pour thousands and thousands of dollars into this or millions of dollars, billions of dollars into this. It's making innovative changes that makes the lives of people easier, puts us
Can you give
all.
us an example of like just a?
So I mean, in terms of some of the issues with equity in general, for example, like and
Mhm.
which happens in medicine, is that there's these medications that exist out there, like antiretroviral medications for HIV, and they're incredibly expensive. And in Canada, we have it all paid for our population. But if you go to other nations, they don't. So ensuring that the costs are down so that people can afford it would be helpful, and it actually saves the society much more costs further down the line as well, like everyone in our world.
Yeah,
We saw a lot of inequity with vaccines and the distribution of vaccines, especially during the pandemic. There was
okay.
groups who got preference over the vaccines over others. There was groups who couldn't access the vaccines.
Hmm.
These were all, big issues that were very difficult to overcome. I mean, then on the same token, innovation can bring about equity. So, for example, we pivoted to a lot of virtual supports during the pandemic from a medical perspective.
Okay.
And it made the lives of a lot of our patients easier, especially those who had phones, but had
Yeah.
other commitments. So, like a lot of them have kids that they can't drop off, they couldn't make it to their clinic appointment. And so being able to actually just do a phone call or a Zoom call like made a huge difference to them.
No kidding.
I mean, just the fact that people didn't have to commute 2 hours to get to work. They could spend
Yeah.
more time with their family, or they could, pivot their work and work two jobs now because they're able to do some stuff virtually. I think very much created a little bit of equilibrium, if you may, amongst those who are underprivileged.
So what do you think about the fact that now, like I feel like what I'm seeing is that places that were using Zoom for patient care during the pandemic, some places are now wanting to stop that and they're all wanting to go back to everything being in person. So it's
Oh,
almost like there was innovation that created more equity and with respect to access, but now we know how to do it, we know it's doable, and yet you see it being taken away.
100%. And I think it should be a patient choice and
Hmm.
preference. It's not really up to us as clinicians. I think it should be the patient's choice. A lot of them want to come and see us in person.
Hmm.
Absolutely. Come and see us and talk. They want to see their clinician, but others are just like, I am busy. Like I've got kids to take care of. I've got, work commitments, or I've got other issues that I'm prioritizing. And so and that's fair too. And then sometimes you need to make a negotiation. I've got patients who I do virtual clinics with, but I'm like, you know what? Yeah, I think you need to see me. Like I think I need to lay eyes on you. We need to discuss things. I need to do a physical exam.
Mm-hmm.
I'm worried about you. And so then you push the agenda of having an in-person meeting.
Yeah. Yeah.
Having
At least sometimes, like you said, right? Like maybe I do think that a bit of both is good. Like for me, I found in mental health, you would think that like with video that would it be the same, and it's not. Like in terms of, in psychiatry we have something called a mental status exam, which is kind of like not so much what the patient is telling you verbally, but it's our observation of the patient, their behaviors, their movements, their eye contact, their expressions, that kind of stuff. And I definitely felt like there was some of that lost when I was trying to do virtual care. So I thought that was sort of interesting.
If you
What
don't
other?
mind, I just want to take a
Yeah.
quick break, and
Oh
then
yeah.
if we can, yeah, we'll come right back to it. Okay, this will be a short one. Thanks. I'm not sure if you've heard about our new podcast, Morning Cup of Kindness. It's a quick 5-minute story about some sort of kindness to get your day started on a positive note. The other thing we've done is to tie it in with being able to promote a nonprofit or fundraiser for absolutely free. All you got to do is tell a 5-minute story about kindness of any kind that will turn into an episode. These can be either submitted or recorded with me inside virtual studio. It's super easy. It takes less than 10 minutes. It's a super easy thing to do. And when you're done with that, you can take a minute at the end of the episode and promote a fundraiser or nonprofit or otherwise good cause. And this can be pre-recorded promotion, or you can talk about it at the end of the episode, or if you want some help making a commercial and putting something together, I'm more than happy to help with that as well. Shoot us a message at ashestowasomepodcast@gmail.com, or just DM us through any one of the socials. If you see the logo there, you can shoot a message. All right, guys. Thanks, guys. Now, back to the show. And remember, if you've got to be something, be kind. That's that.
I like
I
how
like
you included the drawing. It's so cute.
Right.
Well, you know what that
Is that supposed to be a sun?
I got to try and get this off.
Yeah.
Yes.
Cute.
So
and it said
I asked,
Ryan's daughter drew it.
Yeah. So I
Aw.
said, I want your daughter to do this, and then we can share it, right? Like I can put it on forever for as long as that podcast is on. We'll keep her son on there. And as she grows up, if she wants to, redraw it, she can, whenever. If it's once a month or 6 months or a year, whatever, right? Just an Easter egg for her.
We'll see Mackie's son evolve.
Right? So,
We'll see her sons evolve as she gets older.
Yeah, right.
Right?
That's what that was
Evolution
the
of
idea.
sun.
Yeah, right. So
Yeah.
I'm just trying to figure out how to get this. I'm not sure if you've heard about our new podcast. What the heck's going on? Oh no,
We're just going to keep
stop
listening
it.
to the birds.
We're not going to do that. There we go.
Yeah,
I don't
and
know
the
what to do
birds.
here. We'll just keep talking, and then it'll figure itself out here eventually.
One of the things I was going to ask Monty to share his thoughts on. So, like with Attica asking what you love about doing addiction medicine, one of the things that I have found, and again, Monty and I would work with somewhat different populations because his background's internal, mine's psychiatry. But I feel like when I work with patients suffering an addiction, by speaking to them like a human, which sounds really ridiculous, but it's true. But by speaking to them like a human, who listening to what they have to say, meeting them where they're at, asking them what they're hoping I can do for them, and then by being their advocate, and I go swinging. Like I will, I have managers on my back all the time. Like, why is this person still here? And I'm like, because they need to be here. And it's my license. And so they're going to stay and we're going to help them. But they're one of the most grateful groups of people. And Monty, you probably even see this in a lot of other areas of your work because you do work with marginalized populations that are not purely just in addiction. But it's like when people have lived through suffering and trauma and stigma, and then they meet somebody, and maybe even particularly meet somebody in the role of a physician who does want to help them and who they believe actually gives a shit, like actually does. I just find them so appreciative. I get so much out of it because they end up being so grateful and so happy that you're like, and sometimes, the help that they're getting is not what I want to give them. Like I might be like, well, I think you need to go to residential treatment. And they're like, yeah, thanks for that, but I don't want to. And so, sometimes it's not about me forcing what I want on them, or it's not the cases where I'm getting to do the things I think they need to do, but just by treating these people well, like they're so grateful and they're so appreciative, and that is so rewarding.
Keeping in mind, healthcare system. I mean, we can talk about police being, stereotyping, and the healthcare system is rough on somebody in addiction.
Totally.
For me, outside of violence, the most traumatic thing to ever happen to me was in an emergency room as a drug addict. Right? It was awful. It was absolutely awful what happened there.
Like,
right?
I would say that in my experience, just like talking to people in the alleys and just doing my work in the alleys, I would say like over 95% of people have been kind of like not receiving care in the emergency room and actually just being forcefully dismissed, like just because of the stigma or like because of foul language. And I'm like, are you serious? Duh, there will be foul language. What do you mean foul language? It's like, well,
Yeah.
the last education they had is probably like sixth grade, or like probably like eighth grade. Like, what do you expect? Like, just like talk to you like PhDs, like, it's like if they're, it's like,
I don't know.
I
Lisa's
think,
got a trucker mouth on her sometimes. Right?
I think there's the space in medicine to kind of like, sometimes you just gotta talk the way, the way you talk in the streets. And I really, I think there's that work to be done in medicine, because we shouldn't dismiss someone for foul language. Are you serious? Yeah.
So Monty, do you find the same thing that Lisa's saying there, that that subset of people is a little more appreciative? And
You know what? It's all about treating people with respect. That's
Yeah.
what it comes down to. And we're all people, as Lisa mentioned, and it's just about treating them with respect. And they're no different than yourself or myself. And circumstances shift and change. And so like and I'm very grateful to be where I'm at. Like I recognize it's a privilege. So growing up, we weren't very rich. We lived, like I think,
what part of town?
look,
What part of town?
yeah, we were immigrants. I came from an immigrant family. We lived in a small condo.
Northeast.
My father had worked two restaurant jobs, and
Wow.
then my mom was in school, and he had his first bout of cancer back when I was a kid,
Oh,
and we were thinking of moving to the States at the time, and I recognized that if we had moved to the States, we would be bankrupt as a family, because not only would he not be able to work because he's going through chemo. But my mom, I mean, she would have to find a work, but she was in school, and the private healthcare system in the States is so expensive
yeah.
that we would not do well as a family, and so very grateful for the Canadian system because we ended up staying, and the system was able to take care of us, and the community was able to take care of us. We had that sense of community. Like there was a lot of other South Asian families who were very supportive and drop off food and would babysit me and whatnot. Was when my parents went through their situation, my father went through a situation. So I mean, it was that sense of community. But I think that's what's also lacking sometimes. That's what we need to build in our society, is that sense of
Mm.
community for each other. It's
I
one thing for the South
find,
Asian people together, but yeah.
yeah, I find that what I tell to people from like, being in like the hood or like the alleys, it's people who have the least actually give the most, you
Mhm.
know? Isn't
Oh,
that
yeah. Yeah.
really odd, But they were
I
like, there
agree.
was this one time, there was an OD, and then like in the curb of the street, like basically because of speedballing, cocaine and alcohol mixed together. And after that, like she cried so much, and she just like, I just want to go home. I just want to go home. And I'm like, okay, well, let's get you a bus. And then there was someone who's like basically gave like cash, like $10, and she's like, she doesn't have any shelters. Like, I know her, and she doesn't have any shelters. She just like, okay, like digging into the little wallet, and like that's the only cash she had. And she just like giving it away. Like,
Mm.
okay, there you go. Please
Yeah.
take the bus and go back to your Airbnb. And it's just like I almost never gave cash actually.
Mhm.
And she just giving it away like that. And it's just, yeah, like you said, Monty, that sense of community and giving away, it's much more prevalent in people who have the least.
Mhm.
And I think too, like just to add on to what Monty said, like it's about respecting people. It's also, and I guess maybe I'm thinking more like within the healthcare system, like is to just care about people, which sounds obvious. And it's like if you go into this profession, you would assume that that's what we would all do. And I always remember this particular case I saw. I was a resident and I was on call, and somebody had come into the emerge. So my staff was at home and they had come into the emerge, and it was primarily an addiction issue, but they were asking for help. And they'd been admitted a bunch of times before, right? And that's always looked at. How many times have they been admitted? Do they leave against medical advice? Do they follow through on what's recommended to them? And it's like, okay, well, they have a disease that's relapsing, remitting illness that has a very high relapse rate, particularly for people who don't have a lot of support when they leave hospital or they leave residential treatment. And I remember calling my preceptor up. And this speaks to what I had experienced as a resident leading up to this point. And so I present the case to my staff who's at home, who's listening to this on the phone. And I was like really selling that they wanted the help, they wanted to come in. Um, and then, like took a breath, and my preceptor was like, so what you're telling me is they want help, and that's what we do. We help people. So help him. And I just remember being like, oh, like, world off shoulders, right? But again, it's because I had run into cases where this would get rejected. Like, no, they've been admitted 10 times, they don't follow through, they're not serious, like kick them out of the emerge, basically. And it's so simple. This person came in, they wanted help, help them, period. And it
Mhm.
sounds so simple, but it's not always what's done, which is really, it's really sad that it's not always done. And some of that is system pressure, right, Monty? Like we have limited beds. And so if you've got 5 people wanting the bed, who are you going to give it to? You're not going to give it to the person who said they wanted help 5 times before and now they're there for a 6th time saying they want help. They're going to go to the bottom of the list because there's not enough beds. There's limits on the resources we have. Yeah. But yeah, so Monty, tell us a little bit about what you've been up to. Like, so you kind of took us through to how you got into addiction medicine, but like, what are you up to these days?
What's your big project right
it,
now? I know you got something.
Hmm.
yeah. So I mean, I've moved towards, the whole idea of innovation, I think is what really is inspiring to me and pushing the system forward, if you may. I don't know if I'm necessarily pushing the system forward, but changing the system up. And so yeah, I've got a few different projects I'm kind of working on, and it's really related to understanding what the scope of the problem that we're dealing with right now is in terms of the drug poisoning crisis. And so several of the projects I'm working on are all around virtual care. So one is that Dr. Tangi and I had started up the RAM program.
Yep.
So the Rapid Access Addiction Medicine program in Alberta. So one of the big things that I always look at is what are the gaps that we see in our services and our systems. And one of the biggest gaps we saw was that there was no outpatient-based treatment for people who had other substance use concerns outside of opioids. So we had no clinic that took care of alcohol or meth or cannabis or gambling or sex or whatever. And so one of our big pushes was to sort of open up a clinic under our public healthcare system that could provide that support. And so that was an interesting experience. We started
Can you
small and
talk Can you talk, Monty, about, and I mean, for anyone listening, this is a very Alberta specific question, but it's something that even me, like working in what I do, that I'm always kind of fuzzy about. So there's rapid access addiction medicine in Calgary. There's the RAM clinic that Monty's talking about. And then there's also adult addiction services. Now, they started out as two separate entities that are now sort of merged, if I understand that right, but
Mm.
they're still different physical locations. And so,
Oh,
how would you is there not a different physical location?
yeah, they're
Okay. And are
co-located.
they just kind of one and the same, or is there a difference?
They're one and the same.
Okay.
It's just that we're just keeping two separate names because the counselors are more the adult addiction services side, and the RAM, we try to brand it RAM because we're trying to model it after what's going on in Ontario. So in Ontario, they have numerous clinics like these rapid access addiction medicine clinics.
Oh,
And so they're scattered throughout Ontario, and so we really try to sort of work off of using their name because we know that people move tra provinces, they transfer, they go back and forth. There's RAM clinics in BC, RAM clinics in Saskatchewan, so it's like, why, if we're doing the same thing, why change the name? Let's keep the name
So,
as is.
so what is the concept from kind of a macro
It's
level?
low threshold, like basically low barrier access to addiction medicine. So we see
That
people
is
within,
really good.
yeah, we see people within one business day.
Okay.
So very,
Wow.
very quick. Yeah,
Yeah.
and you
Okay.
don't need a
Okay.
referral, right? You can just show up, can't you?
exactly. You just show up. Yeah.
Wow. So is that? I'm not questioning. I'm just curious. As that becomes more popular, do you just get more? Like, how can you maintain that? We'll see people in one day when, it is like,
Well, I mean, we
Good
have to
question.
definitely keep our resources in check, but it's been okay
yeah,
so far. But should we need to have more resources, we definitely have to apply for more funding.
yeah, yeah.
One of the things that
Okay.
we're trying to do is that so now that Calgary has this program, we know the rest of Alberta doesn't. So we're trying to expand it province wide,
Yeah.
and we have some federal grant funding to do that. So we're hoping that that goes through.
Okay.
Um,
Okay.
Edmonton doesn't have any, so I had some phone calls like last night from clinicians in Edmonton who had called me up, colleagues of mine who I went to residency with, and they're like, "Okay, I've got this person. Where do I send them?" And I have to say, unfortunately, there's no clinic in Edmonton that deals with this. Like, there's opioid clinics that we can send them to, but there's really nothing else.
I have a question, Monty.
Hmm.
Opioids is like, yes, it is a big problem, but I do see the emerging non-opiates, tranquilizers, downers, like benzo analogs, which is not reversible with Narcan. And then we have the tranquilizers like xylazine. And what's your experience on that? And where does the role of this low barrier care comes into play? Because now we're dealing with not only just benzo analogs, but we also deal with a lot of, dermatologic conditions due to xylazine. And there's not a lot of literatures on this in Canada. And like, I mean, my research is trying to bring about this data on xylazine, but I think it's a really interesting topic. So, how do you see the innovation going forward with this non-opioid downers?
It's hard to say. I don't know about innovation per se, but we're trying to figure out ways to mitigate it. So for instance, we right now at this moment when we're taking people off of illicit opioids and getting them onto Suboxone or methadone or whatever, we do have a benzo protocol. So we'd get them onto benzodiazepines and we taper them off, knowing that they
Hmm.
could have withdrawal seizures from the benzos.
Hmm.
So that's something that we sort of implemented as part of our protocol. Xylazine, there's no effective medications for that, unfortunately. But I do screen for xylazine, so I do look at wounds and whatnot and make sure that they're okay. Like, we talk about xylazine, the dangers of xylazine. But I mean, the other thing that I'm working on right now, there's a few other projects I'm working on, but we're looking at the wastewater. And we're testing for substances in wastewater, and we're seeing if there's peaks in xylazine levels one week versus the next. And that could serve as sort of an early warning system to our colleagues if there's something that's worrisome. Um,
That's really interesting about xylazine is that based off the work that I do on the streets and the alleys, I've seen people can enjoy benzo. Like, okay, yeah, I can sleep, like I can sleep much easier. It's nice. But I've never heard anyone who likes xylazine. Never. Not even
Is it being
once.
used as a street drug unto itself, or is it a cut?
It's like a
But
cutting agent, isn't
They're
it?
cutting
So
the
it's
fentanyl
like,
with it now. Is that, I know that's what they're
yeah,
doing
so
with the
it's
benzos.
mixed
So
with the fentanyl. I always like when I
okay,
see an OD, even though it looks like a trank, I
yeah,
would I would administer Narcan because I just assume that there is an opioid with it,
yeah,
especially fentanyl, because fentanyl is really short lasting and xylazine kind of like longer that effect.
yeah. That's why they're
Um,
using it. Yeah.
yeah, but like I've never seen anyone liking xylazine. Never. Yeah.
Um,
Like what's
you
your
j-
experience? Huh?
okay? Go ahead. I was just going to ask. Go ahead though. Go ahead. Yeah.
Like what's your experience with xylazine users, Monty and
you,
Lisa?
you know what? There's not as much xylazine right now in Alberta.
Yeah, I don't
It's,
see
Oh,
it
it's
much.
Okay,
yeah.
we're probably a year, 2 years behind Vancouver, typically for the drug scene,
It's
right?
mostly in
Hmm.
Ontario where you see it. So if you look at
Oh
the
yeah. Okay.
epidemiological
and
data,
BC.
yeah,
Okay. Okay.
it's the 80% is in Ontario,
Wow.
then
Okay.
10%
Okay.
is in BC, then the last 10% is kind of spread across the country,
Hmm.
if you may.
Okay. Yeah. Yeah.
We're starting to see some of it though. Like we've seen spikes in xylazine levels here in Alberta,
Hmm.
and
So you just said about testing the water.
Yeah, can you explain that? Because I don't really get what you're talking
Yeah.
about.
a lot of this work
Yeah.
is built off of COVID.
Hmm.
And so
Okay.
what's happening is that we've got like so one of the big things we do epidemiologically for COVID is that we monitor COVID levels in a city by testing the wastewater for the entire city. And
What do you
if
test
there's
for?
we look for certain proteins in COVID in the water,
Okay.
and
Oh,
it's basically people
That's
peeing out
interesting.
COVID, Pe
Wow.
or
Oh,
peeing
I
or
did
Okay.
not
excreting
know
COVID.
that.
And
Okay.
the levels would
And
show that high inside wastewater. Well, I guess
yeah,
it's concentrated at a point two in the waste. Okay. Okay. Yeah.
exactly.
Yeah.
And so we have this thing called the COVID
Yeah.
tracker, which we monitor the wastewater, and it does correlate with peaks, but usually a few days after. So if
Yeah.
there's a spike in COVID cases, we see people peeing out COVID for 3 to 4 days afterwards.
Hmm.
Wow.
But it also helps us sort of plan things. We know that there's certain levels of viral infections going around. Maybe we need
Yeah.
to change our staffing at the emergency department if we're going to be expecting a
Yeah.
huge influx of cases.
Yeah.
Maybe it means that, like for myself personally, that I'll wear a mask if I start to see that there's a spike in cases going on in the wastewater.
Hmm.
But we're doing it for substances now too. So
No kidding, eh?
we're looking
so
at
what categorized as wastewater, if you want to elaborate
Like
on that?
toilet water, right? Like,
toilet
Toilet
water.
water.
yeah,
Yeah,
the black
Okay.
from the
water.
sewer
Yeah.
system.
Yeah.
So we get it from the sewer
Okay.
system, and we test it, and we can tell if there's spikes in carfentanil versus
Really?
Cartafentanil.
xylazine
Yes.
versus
Yeah.
benzos. And so we're looking at 48 different agents and their metabolites.
Is this
And
is a new concept, or is this? It sounds like it's been.
Europe has been doing it for a while.
Okay. Okay.
StatsCan was looking at 5 substances throughout, within 5 cities throughout the country for a while.
Okay. Okay.
But we've taken it another step further. And the other thing that we're looking at is how do we test for new drugs entering the market? So
Yeah.
once a week, we do what's called a QTOF, and we basically look at everything in the wastewater, whether
Yeah.
it's new laundry detergents that are into the wastewater or whatever, but then we try to find if it correlates to new drugs that have entered the system.
Wow.
Are you involved in
Wow.
that, Monty? Is that something you're doing, like
Yeah,
research?
that's
Oh,
That's
wow.
so
That's
interesting.
really
That's incredible.
interesting.
And
So
what's
Yeah.
the, like, in terms of tracking the xylazine, like, what are you going to do about it? Like, is it just for knowledge to know that it's arriving in Alberta and it's something that people need to be aware of, or?
the hope is to translate this knowledge to people who can use it. So, like doing drug alerts, for example, would be key for this project.
Drug alerts.
But it's also, yeah, just informing my colleagues. So, like, we had a spike in this drug called lamivudine in April, and lamivudine is a cutting agent for cocaine, and it causes what we call neutropenia. So people they lose their white blood cells, which is the main cells that fight off infection. So we're seeing back in 2012 when I was a resident, we saw a huge spike in lamivudine and cocaine, and we saw a spike in people who were getting admitted to hospital with really bad infections that they couldn't fight off, and they were on death's doorstep. And so the key for what we call
Wow.
febrile neutropenia is to get them on what's called empiric antibiotics or high potency antibiotics that take care of it. And we only usually see this in people who are undergoing chemotherapy. We've talked a lot about chemo, I feel, today. And so people who are undergoing chemotherapy often lose their white blood cells because their bone marrow gets fried essentially from chemo, and so they can't fight off infections. And so you need to get them on antibiotics ASAP, and that's exactly what's happening with some of these patients. So when we saw that 3 week spike in April, we were like, oh, that's
Oh,
something
wow.
worrisome.
No kidding, eh?
What is
Kidding.
it called again?
Um,
The
um,
cocaine
Lamimazole.
cutting?
okay.
The
Uh,
We do need to
memazole?
take another quick break here. Sorry,
Oh,
I to interrupt again, but you know, they're paying for their spots, so we should probably take care of them, eh? Right? Yes. Um, there we go.
Public service announcement. One of the best ways to reduce stigma is with education. If you still have questions that we haven't answered on today's show, you can learn more about Together We Can's education group at twcrecoverylife.org.
Hi everybody, this is Carl with today's public service announcement about naloxone, or, as it's more commonly known, Narcan, a medication that can help save the life of somebody experiencing an opioid overdose. Did you know that in 2021 opioids were responsible for over 7,000 deaths in Canada and 106,000 deaths in the United States? These numbers are staggering, but there is hope. Narcan is a medication that can reverse the effects of an opioid overdose and help save a life. Narcan is available for free at participating pharmacies and harm reduction centers across Canada and is also available without a prescription at most pharmacies in the United States. Now I know most of you won't be around people using opioids, but you never know when it will be around you, and you could save the life of someone who is loved and who loves.
Back from the break.
Yeah, so I mean, I think it's part of, understanding the problem better. Like I think if we understand the scope of the situation better, maybe we can find a solution. And I'm not smart enough to find a solution right now, but if I can frame the problem better and have a deeper understanding of what's going on with the drug supply, maybe we can save some lives. And
That is
that's
always a good
Um,
thing, right? Yeah.
how accessible it is to do like an anonymous drug test in your area. I'm talking about spectrometer
yeah.
because if we're doing like wastewater, presumably it has gone in, right? Like it like
The
been,
idea. Yeah.
metabolized and everything. But with a spectrometer, you're not necessarily have to consume it, and you kind of see the profile. How accessible it is to get that drug checking done.
In Alberta, so it's happening in Calgary and Edmonton. They do have the infrared the spectrometers that are available for them. And so they are doing those tests right now.
When would
Mhm.
these tests be done? Like when like an anonymous drug test?
Well, it's
I'm
it's done out of a van
looking for
and done out of
context.
a
Yeah.
group called Aware. Alberta, they've changed the name recently. It used to be Alberta Addicts Who Educate and Advocate Wisely or Responsibly, and now they've changed it
Okay.
to Alberta Alliance Who
Okay.
Educate and Advocate Responsibly.
I
Okay.
like
And
that
Um,
and
name more.
and like,
yeah,
what's the
for sure.
context for these tests? Is it just trying to keep track of the drug
So
scene,
it's
or what's? Yeah.
informative. So it's informing the population as to what their drugs might be having, and to
Okay.
be more
Okay. Yeah.
careful. And so by
Okay.
being
Okay.
careful, it's like
Yeah.
not using alone, for example,
So
using
you're
supervised.
testing the
Yeah.
drugs, not people. I heard drug
Yeah.
testing, and I thought, okay, now it all makes more sense to me.
Yeah,
So
it's
yeah.
like I like to explain it like spectrometer. I like to like explain to people about the whole drug testing procedure to people. It's like this. You get into a bar and you get a cocktail, you know exactly what's in it. If you're a drug user and unhoused and on the streets like that, you don't know what's in it. Like imagine getting a
Hmm.
cocktail and you don't know what's in it. You think it's a beer, but turns out it's a vodka. So it's like you don't know what's in it, and it's really dangerous that way. And so it's
Hmm.
just kind of like knowing what's in it in the drugs that I think really important. And yeah, it's like a lot of education I find. Yes, it's like I I would go into the alleys and some people like, okay, wait, but like, how does fentanyl actually work? Like, why do I get drowsy with benzodiazepine? And I think there's that space for healthcare professionals um, like I want to be an MD PhD, like, in the future. And like, I really can see myself just going into the alleys and still talking about all these drugs and like,
Mhm.
okay, this is how depressant works. But yeah, there's a lot of education to be done. It's like a part of harm reduction. And now since tranquilizers are more common, wound care is also part of the harm reduction. Um, yeah, it's like a lot of people just kind of asking, like, how does this work? And sometimes they'd really ask the good questions. Like, I would go home and search it up. Nitazines. Oh, what do nitazines do? And like, how does it actually work? Like, what if you mix these things together? Like, so I think um back to Lisa's point and Monty's point about like meeting people where they're at, that could be like educating for the patients, but also for the healthcare professionals, for physicians, because the street, there's a lot of things to be learned on the street. And I personally learned a lot from the street. And I think everything is really transferring really well into medicine, because medicine, like clinical literatures are, they don't grow, like they're not as fast as like the knowledge that you get from the alleys, so yeah.
Yeah.
So
Um,
I was going to say, Attica, the other project I'm working on that you would be very fascinated with is I am actually evaluating the National Overdose Response Service.
oh
Oh,
my
Um,
God,
yeah, so
I
that's one of my
did it.
other roles. So I helped co-found it with Rebecca Morris Miller and others back in the day,
you helped co-found
and
the service itself?
the service itself, yeah, from
Oh
2018 or
wow.
2018, no,
Wow.
2020, and then
Are you
so
also doing research in Norse?
yeah, so I'm leading the research efforts.
So
Um,
you're the one in charge, so that whenever I finish a call with someone, I had to do a lot of data and logging and
yeah.
like all these check boxes that, okay.
Yeah, I
So
appreciate you doing that though, because it's so helpful. It tells us, like, I mean, and Attica, you probably know this already, and you can probably share some more too, more than I can. But I mean, we've had over 8,000 phone calls on the phone line. We've had 80 drug poisoning overdose events, if you may, zero deaths on the line,
zero
that's
Wow.
and
amazing.
deaths.
yeah,
That's true.
Wow.
Even
across
if we
the
have to dispatch.
yeah.
So
Yeah.
there's you're innovative right there, right? That's amazing, and I can't believe you're the guy that you're a part of founding that in the first place.
And don't you love
Yeah.
that he's like not mentioned it until now?
Yeah, not at all,
It's
right?
like
Yeah, yeah.
just
Just
so,
casually, say it to a lot of
yeah.
lives over here. It was a Tuesday, that's what we do.
Like
But
I
So,
it was a
remember
group
doing,
effort. It's not just me, right?
well, of
It's a
course,
whole
of
group
course.
effort.
yeah,
Yeah.
like I remember like during the training, and they told me to like, okay, you always have to log, and there's like these questions that you have to answer every time you log in. And I'm like, who is in charge of this? Like this is so
Mm-mm.
much
Well, I don't know if
So,
I'm in
checklist and
charge of that, but it helps
data
me.
collection to do.
yeah.
I love it.
Um,
I love Norse, and I think the culture at National Overdose Response Service is super great. Like I love it because I think I'm like the second person in British Columbia who's a responder. There's like another person, but it's just me and this guy, and that's all we have in British Columbia.
So
And I remember,
now that said, are they looking for more volunteers right now?
so we
Right?
always are. I mean,
duh,
Yeah,
Attica,
yeah,
you could
yeah. So
probably answer that better than I can.
I
I
think
think
that's
so.
definitely something that we
Because
should put in the show notes. And how would somebody reach out if they wanted to? Sorry, to interrupt you, Attica, but I think this is a great time
Yeah.
to mention this, right? So,
yeah,
how would they reach out if somebody wanted to volunteer and help out with this?
I mean, you could go to www.nors.ca
NORS.
and
Yep.
yeah, NORS,
Okay.
and
Okay.
that's it. Or call the hotline.
Okay.
And the hotline number is 1-888-688-6677.
Perfect.
Or
Perfect.
the
Okay.
other
And
way
I'll
to
put
say
that in
it
the
is
show
like
notes as well, of
NORS.
course. Right.
Yeah.
Yeah.
But
Yeah.
1-888-688-NORS. And then, yeah, no, Attica, like I appreciate all that you do because it really helps us understand what's going on with the service. And like, so like hopefully we can publish this soon. Like it's in the publishing world limbo. But we've seen data that shows that that the people who are using, like, we've had zero deaths so far. We can sort of predict deaths. Like, one of the big things that we've seen is that women and gender minorities use the line predominantly. And we're trying to figure that out because we have the exact opposite ratios in terms of people who use the service to those who use physical surface consumption sites.
Yeah,
So
and
Wow.
what I really like
That's an
about
interesting
National
thing.
Overdose Response Service, like it's free and it's anonymous. Like when someone calls in and I'll be like, "Hey, I'm Atika, like do you have a code?" So we just take like the first two letters of their first name and then first two letters of their last name and then the last two digits of their year of birth. And it's 24/7. It's like McDonald's. It's like, it's like always open, and I'm usually at night. And um I remember like bringing all these like Norse sticker, like the swag, the little circle sticker, and just put that everywhere in the alleys in downtown Eastside Vancouver because a lot of people don't know. But
Mhm.
as you know, Lisa and Monty, the highest overdose deaths are when people use alone.
Mhm.
And what I see from the experience working at the like a safe consumption site is that when you're a user, sometimes it's kind of lonely, like you just want a company and you just want someone to talk to. And, using can be very lonely. And if we can kind of like provide companion at the same time, preventing overdose, like why not, right? So
Mhm.
So I was gonna say,
Is
Attica, like you talk about, like I think the secret sauce for the whole service is the peer support.
peer support.
And it's that companionship, and that's what we hear over and over and over again, is that people love that aspect of it.
They do.
And it's so important. And the other thing that I think was really interesting is that almost two-thirds to 70% of our callers can't access a physical surface consumption site.
Yes. So
And
even though there's like, yeah, they do exist, but they don't open 24/7. If they do open 24/7, you don't always be like, you can't always access it. Like that's the same thing as like the clients that I've seen from the downtown east side. It's like they can't always access that. So it's really nice to kind of like have it's like a phone call away. It doesn't eat up your
Huge.
internet
Absolutely.
data,
Yeah.
so
Right.
yeah,
do you
yeah.
think, Monty, that women are using it more because, like, if you think about a female user, right, they're more vulnerable, right? Sexually vulnerable, like abuse vulnerable. Like, do you think that in part their choice to use alone and rather use a service like Norse is that they're less worried then about, being abused or being violated or whatever?
yeah. So we're wrapping up a qualitative study and survey with females or gender minorities who use the service.
Mhm.
And that's exactly what we're hearing, is that
Mhm.
it's a fear of violence, fear of being seen in terms of like running into people, like if you were involved in the sex trade, running into clients or your employers in the past.
Mhm. Yeah.
It's children, and so a lot of them have children that they can't leave at home, and so they use the Norse line.
Right.
So those are the various different factors that we're hearing from our respondents, that they tell us that they're like, these are the reasons why we're using the service. They feel comfortable. They enjoy the fact that they have a companion on the phone line.
Mhm.
And so yeah, that's the general sense that we get. And it's they and so yeah, the vast majority, the way vast majority of our callers in Attica, you've got like you've got first line experience in this. I mean, I read reports, and you're on the front lines, hearing their voices. And
Mhm.
so like you'd probably be able to say that like uh, like what's your take, Attica? Like, why do you think that they're females, or most of the, or people who are gender minorities, are like the most likely callers of the service?
Yeah, I think that's the same of like what you said, Monty. Like sometimes they have kids and like they don't want
Mhm.
the kids to know. So when the kids go to school and she just doesn't have access to the safe consumption set, they just call in. I've had great experiences with some of these clients. Like some of them are like, it's like really fun and engaging that I would like, have a shift for like 12 hours and it just flies by. Because it's like sometimes I
Yeah.
get like, oh, Atika, I'm writing this little fiction. Would you care to hear about it? And then I'm like, yeah, sure. And then it's just like listening to like, some of my clients writing piece, and like sometimes it's like a really good way to connect in terms of like, oh, what's like a safer use, and like sometimes I educate, but most of the time I'm the one getting educated by them because it's like
Jesus.
sorry. Yeah, because it's like, oh, I didn't like, what's your take on Suboxone? Like, in times I'm the one asking those questions, like, oh, why do you choose Dilaudid instead of Suboxone? What's your take on methadone? And, so in times I just actually getting quite educated from these female clients.
And what I hear too in that story, Attica, is that like, so A, it's preventing deaths, which is, prize number one, but also just that building relationships, that connection, that
Rapport.
education piece. Like that may, it could be one of those conversations that triggers somebody to take the next step where it's like they're not just using safely to prevent their death, which is great, but they might even, take the next steps towards recovery
I
or,
think so.
which
Yeah.
is
So, I
really good.
mean, we have a great story that we published at the Canadian Medical Association Journal around NORS, and what I'll do is I think people just have to Google it if they're listening in. But it's around one of our clients named Jessica, and I don't know,
If you
Chuck,
send
if
me
you
the
can
link,
post it
Monty,
later.
I'll definitely put it in the show notes. Yeah.
Yeah, and I've posted in the chat box, but
Okay.
essentially Jessica was a patient who so when Norris first started, we didn't have enough operators, and so a lot of us
Yeah.
were operators on our own end. So I was one of the operators too, and Jessica was one of my favorite patients. Like or clients, I should say, with the Norris lines. Like she would call, and she was involved in a lot of different things, but highly vulnerable. And I met her on the line for the first time, and she would listen to Drake songs with me as she would use her drugs. And we just talk about Drake. And
Oh my
then,
God. I can
and
relate. Like
yeah,
in
you
times
just
like
listen to
I would
music.
see patients, clients, they would like, oh, can I put on this song? I'm like, yeah, sure. And then we just listen to it together. Or
Yeah.
like I remember there's one client that just like really, really like super cute. Like she would be like, I have this list of topic of conversation. Which one do you want? Like we can talk about you, we can talk about me, we can talk about Drake, we can talk about something else, but it's always like 4 or 5 lists of conversation to have while they're
It,
using. And I like to kind of like, oh, how do you feel now? And like getting like tips about harm reduction, because I think users are actually experts in
yeah.
harm reduction. They are experts. Like they know how to save lives. And I learned a lot more from them than I've ever been in any hospital certifications I've had. Like, yeah.
Yeah.
And
I
so did
mean,
Jessica end up, because that story kind of came about talking about this, beyond just saving lives. Like, so can you give
it,
us a synopsis of her story?
yeah, I mean, the bottom line is that she really enjoyed the peer support that she got on the line. And then the peer support, eventually she was ready for wanting to get onto buprenorphine Suboxone. And so the peer support worker on the line connected her with another peer support worker at a RAM clinic. And
Oh,
then she connected with me. And then we were able to put two and two together that we used to be on the line with each other. And then Jessica's done well. She moved back to Ontario from Alberta, and she's thriving out there, and that's her story. Like, so that's she wrote that part of the story. It's from her perspective,
nice.
and so which is really cool too. So like, feel free to take a read of that and see the different perspectives of her journey. But like Jessica's just one of various stories that we have on the Norris line, and there's so many different groups that are on there, and there's so many things that Norris does. So it does peer support, it does mental health first aid, it does methamphetamine psychosis de-escalation. Like that is the other thing that we were really surprised about. Like, like there's no other service that does that where people are in active psychosis and the Norris operators are able to de-escalate the situation. They're able to
Yeah.
say, turn
So,
off the
so in that
lights.
case, would it typically be a family member that called, or a loved one that would call in, or the person
No,
themselves?
Person
they person themselves using methamphetamine and they would call. I had
Okay.
that actually. I think
Okay.
people on methamphetamine can experience wide range of effects, and
Oh yeah,
it's
it's all over the
really
map. I've said that for years,
it's
but
really like really
but-
heterogeneous in that sense, and like you said, Monty, like some people just literally just have bad trips, and like we kind of like help them, stay
So
grounded.
where I see it, and because we focus so much on the families here on Ash Just Awesome, right? What I'm thinking is this guest that I'm interviewing again this weekend. We tried earlier this week. It didn't work out. One of the things she talks about often, her and her son were talking about, is her dad or his dad, her ex-husband, with the psychosis, right? So could they call Norris and say, hey, what do I do? Like, this guy's, and he's still, I mean, he's in early recovery, and, he's a week into it, and they're still following him, and they're still under the car, and they're still, whatever, right? But
Yeah, I mean, it's more about de-escalating the situation, right? So if they're experiencing psychosis, like people like Attica would just reorient them to reality.
Yeah.
okay.
And
Okay.
and
Like we're
and
not gonna be like, oh, you're in recovery? Okay, bye. Bye. Like we're just
Well, no,
gonna be
of
like,
course you
okay.
wouldn't. Of course you wouldn't, right? Yeah, no, I just mean, like, how to de-escalate that, and it's for them. I wasn't even sure what to say, right? And Ryan had suggested, well, just let them believe what he's going to believe, because there's no point in trying to tell him different, right? So, so.
Sure,
Yeah,
but I mean, the line is great. One thing we are doing is like, so we're running out of funding as of April 2024, but we're going to try to find some more. We always have this battle every year. We have to renew our funding, and
These
so
operators gotta log in the data. The goddamn data. This
yeah,
data's mean funding.
Do you find it hard, Monty? Because I feel like it's obviously a service. I mean, you guys are saving lives, like very literally. Do you have to fight? Like, is it hard to get that funding renewed? Because it shouldn't be. Like, when you're a service saving
It's
lives like
hard.
that, they should be throwing money at you.
it is a tough
It's hard.
slog, to be honest with you.
It's hard.
Like we talk to provinces and they're like, oh, it's a federal program. The federal government should be paying for it. And then the federal government will be like, well, provinces fund healthcare, not the federal government. And therefore it should go to the provinces. And so that's kind of the loop that we're in as a national line, is that we're this like constant situation. But I mean, I do think that like with the help of people like Attica, like the data that we're collecting, like I believe in data-driven advocacy. I'm a nerdy scientist, and so it's for that reason that I'm like, we have the data to show it works. We have the data that shows that 70% of people can't access a physical service substance site because it's not in their city. It's not, its hours of operation are off limits, or they are using inhalational substances and they can't use in a physical SCS in some respects. And so like, these are the things that kind of come into play, and that, there's just so many different things that we're able to show with the service that are demonstratable. And actually, Attica, like you're like the other thing that we're looking at right now is the benefit to the operators. And so, as of next week, we're launching another study within the NORA system. You'll get an email about that to come from Pam probably.
I will. And I'll be doing the data logging
Sure,
again.
right? But it'll be interviewing our operators and doing a survey with our operators to see what their experiences have been like with the service. And then on top of
Yeah.
that, we're talking to the clients. And so we're reaching back out to the clients and doing another survey and also another qualitative study with them to see what their experiences are like, and asking them a whole new range of different questions than we've asked before. We've published quite a bit on this already, but there's just more that needs to come, and things that we need to show and demonstrate to Health Canada. That's the biggest thing, is that
So
Yeah.
who
And
is funding it now? Is it federally funded or is it provincially funded?
it's Health Canada.
Okay.
And Attic, if I had to show you like so Lisa Morris Miller is one of the other leads of the program, and her and I have to fill out, I think, a 50-page document once every 3 months that we have to send to them with all the data, all the
Oh my
stats,
gosh.
what's happened with the line.
I think like my logging was bad. Like I have to like do this questionnaire every time, and then I think about you, Monty, and I feel
Well, I
better now
appreciate it.
that you're doing that too. You're doing that, Monty.
Yeah. It takes
I think
it takes a long time, and we have to write stories and what's happened, and it's a long document. It comes back and forth, and do we have to analyze all of our statistics, and so it's a process, but it's gonna be worth it. Honestly, I
And
think
maybe
it's
some public awareness might help. But to get kind of campaign
Yeah.
behind you. I think I'll commit to it even right now, as we're recording it, we'll certainly throw in an episode or a commercial for it, if we can work
And
together and
like
figure
what
something
I
out
like also
in
about
our
Norse,
episodes, and
yeah,
keep, try and get the word out. Absolutely.
yeah,
we can
what
do
I
that.
like
Yeah.
about Norse also, it's like there are some times where I would respond to someone witnessing an overdose or after witnessing an overdose, like, oh my God, like I just witnessed an overdose. And it like sometimes can be really stressful. Like I've seen enough overdoses that I'm kind of like, okay, like I can like kind of compartmentalize, but I think us as peers, it's like you said, Monty, about that peer support, supporting someone who just witnessed an overdose the first time, kind of like debrief. So it's not always just about the user. It can be family. It could be someone who just witnessed an overdose. Can be someone who's like, I'm not sure if this is an overdose. Is this an overdose? And we will go through the whole process with them. And the thing about Norse is like if we have to dispatch, there's like a North line of it that they know exactly. It's like 911 for overdose. Like we know exactly it's an overdose. And what I experience from consumption sites, it's like we call 911 and I'll be like responding to an overdose and they'll be like, do you need a police, firefighters, or healthcare? And I'm like, dude, okay, this person is overdosing. Okay, like I just need you to get here right now, like
Yeah.
and so it's like as a responder, it's really really frustrating to just like be on the line for like 30-40 minutes and they're gonna say like, your emergency is very important to us, please stay on the line, like so I think having that
Yeah.
access at Norse that we can just dispatch and they know exactly we're dealing with an overdose, they know exactly where to go, it's super helpful, super helpful. It does bring me sanity in that case. That's for your study, Monty.
Yeah, sounds good.
Operators,
Well,
right?
mention that because they'll be interviewing you. We have a whole group of interviewers who will be interviewing all the operators, and you can share your thoughts and be open about it. Like because I think
Yeah.
that's the key thing that we have to show is that because like they're honestly, like I hear it from other operators too, Attica, like your colleagues that they tell us that it helps them as well with their own wellness. And
Yeah.
and they enjoy it. And there's this culture, as you mentioned, Attica, that just really permeates through the service that they're all there for each other and so it's amazing to see. And then I'm like I feel very privileged to be a part of the project and to be able to work with everyone there. So it's super cool.
No kidding. No kidding. Well, I think that gets us towards the end of it here, Monty. Is there anything that you'd like to say on the way out here? And
No, I mean, I had a great conversation today, and it's great to meet Attica. Like, it's great to meet one of the operators. So thank you.
yeah,
And then,
that's
and I
crazy.
mean,
It's
I've
funny you
met
two
Lisa
didn't even
before
know
and
about
yourself,
each
Chuck.
other,
It's
eh?
great.
Yeah, yeah. I really got to thank you for coming on. Yeah, we're not done with you because well, we've got this daily gratitude thing that we do every day that I forgot to tell our guest about again. So that happened. Lisa, I feel like that's going to go under your purview from now on, right? Yes.
Okay.
All right. So we'll do our little thing here. That brings us to my favorite part of the show, and that's the daily gratitudes. Do this first.
Today's Daily Gratitudes are brought to you by Revolution Recovery, helping men recover and become their best selves through support and treatment. They've been there and they understand.
So every day we do some daily gratitudes, or every episode, Monty. And whenever we have a guest, of course, we get at least a couple out of you if we could. That'd be great. Hey, I'm sure you got something to be grateful for.
Oh, 100%. I mean, like I think I just said it a couple seconds ago that I'm grateful to be able to work with Nors and the team there and learn off of all my colleagues there. I mean, it's been a great experience, and I'm grateful for all the opportunities that have come my way. And as Lisa knows, it started off that there's no jobs, but things happen for a reason, and grateful for those opportunities. And actually, I think that's the biggest thing that I learned, kind of starting from that place, was that every opportunity that came by was a bonus, and I'm grateful for that.
Excellent. How about you, Attica? You got a couple for us?
I am so grateful to talk to Monty, Lisa, and Chuck. And now I'm so even grateful that I know who it is behind the Norse other than Rebecca. I know who to blame if I'm frustrated about doing the little questionnaires every time I finish with a client. But I'm really grateful for Norse, and I love every single one of whoever is the other side of the phone, because harm reduction comes down to love at the end of the day. And we're here to save lives, and it's really fun to save lives. So, yeah,
Your story.
that's what I'm grateful for.
Lisa, what you got for us?
Every single week. I'm grateful
week,
that my
yeah.
brother is still sober. My brother is going on over 5.5 months now on this particular journey, and I spoke to him just a few nights ago, and he's doing well, and I'm grateful for that. I'm also going to say today, so my little one went back to school this week, right? So everyone's back to school now, and it was really funny because throughout the week it was a bit of a hectic week, right? Like she's back to all her activities, she's back to school, and I was working in Emerge this week, which I do every other week, and those are always busy work weeks for me, and so I was kind of feeling sorry for myself the other night, and then I stopped and thought about the fact that, I have friends who've lost kids, to various things, and it kind of just popped into my head and made me stop and realize how lucky I am to have a healthy little girl going back to school who's busy and vibrant. And so it was just a good shift in perspective that I'm lucky that I've got her. So I'm choosing to be grateful for my busy week that I had this week.
Good stuff. Good stuff. You got to be busy, as Carl would say. Right?
Yeah, exactly.
Yes, yeah.
I didn't have
Absolutely.
to be. I got to
Absolutely.
be. Yeah.
For myself, I'm grateful for another excellent guest introduced to us through Lisa, of course. Thank you so much for coming on, Monty. It's a big deal. We really do appreciate it, and what a great conversation at that, right? And my final gratitude will go out to you, the listeners. Whatever you guys are doing, please keep doing it. It's we're still growing somehow. It's kind of amazing right now. And if you see our logo on any of the socials, I'm not even going to list them all anymore because there's so damn many. We are literally all of them. Drop us a comment, like, share, do whatever you got to do, because every time you do any one of these things, you're getting me a little bit closer to living my best life. My best life will be to make a humble living spreading the message. The message is this: if you are in active addiction right now, today could be the day. Today could be the day that you start that lifelong journey. Reach out to a friend, reach out to a family member, call into detox, go to a meeting, do whatever the hell it is you need to do to get that journey started, because it is so much better than the alternative. And if you have a loved one who's suffering, if you have a loved one who's suffering an addiction right now, you're just taking the time to listen to the Weekend Ramble. If you could just take one more minute out of your day and text that person, let them know they are loved. Use the words.
You are loved.
That little glimmer of hope just might be the thing that brings them back. There we go. Perfect.